talking about the new place of delivery guideline, credit to Shuba Barwick, who helped with this and also did the first generation of the guideline. So the rationale for this is that obviously we want to ensure that babies with congenital heart disease are delivered in the most appropriate setting. And this is to allow optimal management of their cardiac condition, but also having reference to maintaining the family care and the support network around the family. So in principle, we want people to deliver as close to home as possible. The guideline was updated earlier this year and has been approved. And as Shuba alluded to, this became more urgent last year when we sadly had a baby, a mother who was a multip, who lived over an hour from Leeds, had an induction of labour planned at 38 weeks, but due to capacity issues, she was postponed on 2 consecutive days. And then on the morning of the 3rd day, when actually we did have capacity, she sadly presented in her local hospital in labour and delivered, and the baby died before they could be transferred to Leeds. So that brings home the importance of the right place of delivery. As we've heard, 50 to 60% of congenital heart disease is now diagnosed antenatally, and some of these babies will have duct-dependent pulmonary or circulatory or systemic circulation. So these are babies that will need a prostaglandin infusion pretty soon after birth. And a very small percentage will need a septostomy or other emergency treatment immediately after birth. So in general, our principle is we want to make an individualized decision. As Shuba's outlined, it's dependent on the specific cardiac anatomy. It should bear in mind the family circumstances as well, and to some extent the geographical location. We cover a very wide region in Yorkshire and Humber. It also needs to take account of the past obstetric history. The case I was discussing earlier, I think she was para 6, and unfortunately cot capacity does become a pressing issue as well. So these slides are basically just extracts from the guideline. The guideline is available on the Congenital Heart Disease website. So as we've heard, most people have their normal anomaly scan at 18 to 20 weeks, and then some will have a fetal echo. There needs to then be very close liaison between fetal cardiologists and fetal medicine and neonatology to plan the place, date, and mode of delivery. In general, the letters will be sent to the local obstetrician, and they will appear on the Leeds PPM system. There's an expectation that if the baby is going to deliver locally, then the local obstetrician will liaise with the local paediatrician to plan delivery. The timing is usually for induction of labour around about 39 weeks, unless there's an obstetric need to deliver earlier or the baby is compromised. It's important that although the cardiac side of things is centralised in Leeds, the rest of the antenatal care is usually delivered locally. So all the mother should attend all their normal antenatal appointments, and any independent obstetric complications should be dealt with locally. And obviously this requires very good communication between the referring and the receiving unit to make sure that changes in plan are updated. Just in terms of timing of delivery, there was a study published in 2017 that looked at a registry of 3 million births, of which quite a small proportion had congenital heart disease. And they not surprisingly showed that the outcomes were worse the more premature you were. So maybe not surprisingly, being born 34 to 36 weeks had a 9% higher risk of death or morbidity than being born at early terms, 37 to 38 weeks. But what's quite interesting is that's even maintained within what we would consider as term. So if you're born at 37 to 38 weeks, there's still a 3.2% higher risk of death or morbidity than being born at 39 to 42 weeks. And so because of this, we've intentionally moved the date of delivery to 39 plus 0 if possible. Obviously, some people may have to be delivered earlier than that. So there's pros and cons of delivery in the cardiac centre and delivery locally. As we've heard, we're very lucky to have all our different specialties under one roof. If you're born in the cardiac centre, you're going to have rapid access to the paediatric cardiology team, and it should eliminate the need for postnatal transfer of the baby and the mother. It should reduce the time to definitive diagnosis or treatment, and it should reduce separation of the mother and baby. And although we obviously trying to reduce or minimise and totally eliminate really transfers out of our own cardiac network. However, if you deliver locally, there's also several advantages. It's a suitable and safe option for many women and babies. It maintains specialty capacity in the Leeds neonatal unit for other specialist services such as our surgery and neurosurgery. It allows for unexpected obstetric complications to be managed locally. And in palliative care cases, it allows compassionate care closer to the home and to the family support network. It also facilitates and improves links with the local paediatricians and the local paediatrician with expertise in cardiology, and it builds and maintains local experience in managing babies with moderate or mild congenital heart disease. So the guideline is divided the main cardiac conditions into 3 groups on a sort of traffic light basis. The green group is those that could be delivered locally. The amber is those that could be delivered locally if there's favourable circumstances. And the red group is those that should be delivered in the cardiac centre, so in our case in Leeds. So thinking about the red group first, all these babies should also be discussed with regard to our Leeds capacity protocol, which is trying to prioritise access to the babies to the neonatal unit for those babies and mothers that need it most. And I'm pleased to say that a cardiac baby outside of the Leeds unit is the top of the priority list. The pathway is usually from delivery suite through to the NICU, through to either Ward 51, the cardiac ward, or to PICU. And that's either before or after their surgery. However, we have made some modifications. So if it's a time-critical condition such as a transposition and the mother doesn't live in Leeds, if we can't admit the baby on the planned day of delivery because of capacity reasons, we would now admit the mother, or at least offer the mother admission to the antenatal ward so that she can sit and wait just in case she goes into labour. Transfer out of the cardiac network is very undesirable because of the interruption to continuity of care, and we'll do all we can to avoid that. And it's very important that everybody in the pathway is involved in those discussions if that's going to be the plan. For you people out there in antenatal, if you need advice about this pregnancy, antenatally we suggest going through fetal cardiology or fetal medicine, depending on what the main issue is. But if we're talking about the immediate intrapartum or postpartum or neonatal period, then it's best to go through an embrace transport team who can liaise about in utero transfers and postnatal transfer of the baby. So the conditions which we would suggest do need to be delivered in the cardiac centres, we've heard, is transposition of the great arteries. This is even if there's a VSD, which might allow significant mixing. We try and target these babies to be delivered in the morning. That's in the hope that if they're late, they're then still delivered in daylight hours. This is because there's only a limited number of cardiologists on the interventional rota, and we don't really want these procedures being done in the middle of the night. And ideally, these procedures are now, so septostomy is now done in the cardiac cath lab if it can't be done on the neonatal unit under ultrasound. In very, very selected cases, you might want to consider elective caesarean section if there's a particularly restrictive atrial septum. That's something that needs to be negotiated both with the mother and also with the obstetrician, as there's an understandable desire not to go for caesarean sections unless really necessary. Left-sided heart lesions, which are duct dependent, so hyperplastic left heart, HLHS with restrictive septum, we should definitely try and deliver in hours. Hyperplastic aortic arch or interrupted aortic arch, or a high suspicion of coarctation. And the latter group is particularly advantageous to deliver in Leeds because they can then have an echo and be monitored as the duct closes with serial echoes rather than being started on prostaglandin, which can often mean the baby needs to stay in hospital a lot longer while we wait for the duct to narrow on stopping the infusion. If there's duct-dependent pulmonary circulation, such as pulmonary atresia, if there's anomalous pulmonary venous connections, or if there's severe functional abnormalities, such as severe cardiomyopathy, tachyarrhythmias or hydrops, or complete heart block with a very slow heart rate, then these babies should also be delivered in Leeds for rapid access to the specialist cardiac services. And then there's another group which is difficult to define, which is the babies with more complex anatomy, and other babies, as Schubert alluded to, these babies often have an overlap with genetic syndromes or with multi-organ problems, and we see a lot of surgical babies who might have abdominal problems as well as cardiac, and so they have to be delivered in Leeds rather than Sheffield or Hull. The amber group, many of these babies will be suitable to deliver locally with early cardiological assessment, whether that's as an outpatient or by the paediatrician with expertise in cardiology or by local sonographers. But if they're complex, then the plan may need to revert to delivery in the lead centre. An individualised clinical assessment is made by Shuba and her colleagues to plan which is the best part of the best place for delivery. And this may take into account local PEC expertise and rota cover for the ability to scan after birth. There's still some of our smaller DGHs that don't have a local paediatrician with expertise in cardiology. And it's important to manage parental expectation here, because there's sometimes a desire to have your baby born in the cardiac centre. So managing the rationale for why that's not necessarily the best thing needs careful communication. So the kind of things that can deliver locally would be other great vessel anomalies such as truncus arteriosus, some transposed great arteries in the context of congenital heart disease, complex congenital heart disease, so things like congenitally corrected transposition, and it will obviously depend on the individual anatomy. And then other pulmonary circulation, which is less critical than pulmonary atresia, so tetralogy of Fallow, they may require delivery centrally if there's very small pulmonary arteries, or pulmonary stenosis really only if there's a planned very early intervention with a catheter. And then some other complex anatomy where the immediate neonatal course is expected to be good. So a double outlet right ventricle with balanced ventricles will usually not need immediate intervention after birth. And we thought it was important in this guideline for reassurance really to also list the things that can safely be delivered locally. And these can usually be managed with early PEC involvement or cardiac outpatient involvement by the visiting cardiologists who usually come once or twice a month. So things like large VSDs, an AVSD with good function, simple tetralogy of Fallow, right-sided aortic arch or double aortic arch, or in small intracardiac tumours, or heart block with a normal or reasonable rate, and SVT that's already been controlled with maternal medication. And there's probably other things that could be added to that list. The other group it's important to mention is palliative care babies. So where cardiac lesions are inoperable, then there may be a palliative care plan agreed antenatally. And I think we pride ourselves in Yorkshire and Humber on our very good palliative care pathway and very good links with the local hospices. So if it's been agreed that there's palliative care and there's no immediate cardiac input after birth, then it may well be appropriate to deliver locally. But this obviously requires a lot of support and guidance from the centre to support the local neonatologist and local PEC. And the hospices should be involved in this care planning as well. Obviously, if there's any doubt about the need for postnatal intervention or urgent echocardiography is anticipated, then you should revert to delivering the baby in the cardiac centre. And we've had several babies now who've followed this pathway in non-Leeds units very successfully. There's going to be a separate palliative care guideline written alongside this. So this is just the outline here. So obviously there can be difficulties with this pathway. When difficulties arise, if in doubt, please discuss with the Leeds cardiac and maternity team. I think good communication is absolutely essential in these cases. Any changes to the pathway, we all know that you can make a plan, but the plan often needs to be changed during pregnancy. And any changes to these pathways should be communicated clearly, both by letter and by telephone and consultant to consultant where possible. And we're going to monitor and exception report these deliveries via the neonatal and cardiac network. So when babies are delivered off pathway, then we will be discussing those individually. Thank you very much.